Thank you, everyone, for joining us at the Better Access Improving Preventive Healthcare for People with Intellectual Disability webinar. I'm Hayley Mills, and I'm part of the National Centre of Excellence in Intellectual Disabilities Health, Learn and Lead group. I'll be the chair for today's webinar. We'll now begin today with acknowledgement of country. As a member of the Learn and Lead group, we respect the First Nations people and elders from this land. First Nations people have lived on this land for many years. Now we live, work and play on this land together. We can learn a lot from all their stories and their knowledge. We will now play a video about the centre.
Hello and welcome to the National Centre of Excellence in Intellectual Disability Health.
We call it the Centre for short. This centre makes sure people with intellectual disability get better health care.
At the centre, we talk to people with intellectual disability to find out what they think is important.
We talk to families and support people.
We work with health services and disability groups.
We bring information together from across Australia.
We share information about how to make good health services for people with intellectual disability.
We make sure there is health information for people with intellectual disability, families and supporters, health and disability workers.
We speak up on the big health issues and drive positive change.
There are 9 main groups in the centre. We call this the consortium. There are also more than 50 wonderful partnering and collaborating organisations. People with intellectual disability are a big part of the centre. People with intellectual disability work at the centre.
We're excited about improving the health and well-being of people with intellectual disability. Please join us.
To find out more information, go to our website nceidh.org.au and sign up for our news.
Welcome to the centre.
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 Yay!
I would like to introduce your speakers for today's webinar. Firstly, we are joined by Dr. Mary Ann Barrington, who is a Senior Research Fellow at the Centre. Next, we are joined by Siobhan Humphreys, who is a Research Officer at the Centre. And finally, we are joined by Suzanne Adrian, who is a Project Officer with lived experience of intellectual disability at the Centre.
Thank you so much, Hayley, and I'll go through what we're going to be speaking about today. But thank you everyone for joining us here for the Access to Preventive Healthcare webinar. So this is a webinar that we're presenting, which is based on a project that we've been working on to try and understand, in particular, preventive healthcare for people with intellectual disability and ways that we can try to improve access to preventive healthcare. So I'll talk a little bit about our project team. So Hayley just introduced us then, but we'll also just talk a little bit more about who we are in relation to the project that we've been working on. And then I'll go into some of the things that we've been finding in our research about how we might be able to support better access to preventive healthcare. And then at the end, there'll be some time left for questions and answers. So as I mentioned, we'll just do brief introductions of ourselves as well. So my name is Marianne. I'm a postdoctoral fellow here, and I have been leading the preventive healthcare project that we've been working on. I'm going to hand over to Sue, who's one of my colleagues, who'd also like to introduce herself.
My name is Susan. Hi. My name is Sue. I am project officer.
And my other colleague.
Hello everyone, my name's Siobhan. I'm a research officer at the centre working on the Preventive Health project as well. So the three of us have been kind of exploring preventive healthcare along with other colleagues and collaborating partners, and we've tried to think about what are the key things that we've learnt so far. So just to give a bit of context to the project that I've been referring to, it's an NHMRC partnership project that goes for 5 years. Currently we're in the 4th year, so we've done quite a bit of the work to date. And the aim of this project ultimately is to develop a model of preventive healthcare for people with intellectual disability. We've been focusing in particular on primary health and models of care that might improve access there. The team working on this project is multidisciplinary. We have co-researchers with lived experience of intellectual disability. We have academic researchers. We have disability service providers and advocacy groups. For example, we have CID, ARUMA, Down Syndrome Australia. We also have healthcare organisations and services partnering, including Central and Eastern Sydney PHN and Western Victoria PHN. So it's a very diverse team that brings lots of different perspectives to the issue. And the reason that we focus on preventive healthcare is because people with intellectual disability have stark health inequities compared to people without intellectual disability. And this is something that's happening globally. So researchers here at the centre recently found that there was a median age of death of just 54 years old among people with intellectual disability. And more alarmingly, 38% of those deaths were potentially avoidable. Some of the key predictors of death for this population are epilepsy, chronic disease, serious mental illness, and cancers. And the important thing about that is that many of these predictors are actually amenable to change with timely access to preventable healthcare. There's also policy initiatives around preventive healthcare that make it a really timely kind of area to be focusing on. So the Royal Commission, I just have here some of the recommendations that came out of that really link to why we need to be focusing on preventive healthcare. Some of these include really needing to enshrine the right to equitable access to health services, have national agreements, strategies and plans, and actually meet those strategies and plans that we agree to, really building the workforce capability, and trying to develop specialized health services that understand intellectual disability health and understand accessible means of communicating. We also have other policy like the National Roadmap and the National Preventive Health Strategies too, which really highlight the need for supporting healthcare professionals in their role, partnership and engagement between sectors and services, and really having a stronger prevention focus and health literacy focus too. So it's really timely to be focusing on how we can improve preventive healthcare for people with intellectual disability. This is just a quick overview of what we've been doing in the project. I won't spend too much time on it, but I did think it would be good to just provide some context of where some of our key findings have come from. So we have 4 arms to this project. The first is policy analysis, where we've been looking at national and international policy and trying to understand whether people with intellectual disability are represented in policy and how they're represented. We've been working on linked data analysis, which is looking at rates of cardiovascular disease, preventable hospitalizations, and immunization coverage. We've been doing qualitative fieldwork, where we've been going out and speaking to people with intellectual disability, support networks, and healthcare professionals. We've been asking them about how they access healthcare or how they provide healthcare, and things that make that easy, things that make that hard, what we can be doing better. And what we're hoping to do with all those 3 streams of work is go into our 4th stream, where we want to use what we found to really design a model of care that can improve healthcare access. Marion's explained that one of our key project aims is to better understand how people with intellectual disability access healthcare. And one of the ways we can understand that is draw on multiple theoretical frameworks that already exist. The first of which theoretical framework we're drawing on is Levesque's patient-centered access to healthcare model. And in this model, Levesque and colleagues considered healthcare access right across the healthcare journey, from the patient having healthcare needs all the way through to receiving healthcare and then the consequences of that healthcare. They then considered that healthcare journey from two angles. The first angle being the influence of the accessibility of services. So this is how approachable the service is. For example, do they do community outreach? How acceptable is it to use the service in terms of culture and norms? How available and accommodating that service is. For example, does it have large hours of opening and easy to access appointments? How affordable is the service? What's the cost of that healthcare? And how appropriate is the service? Does the service have the right technical and interpersonal skills to deliver the right healthcare for that healthcare need? They also considered it from the patient perspective. So what's the ability of the population to access this healthcare? So does the patient have the ability to recognize that they have a healthcare need? Do they have the ability to seek healthcare and then reach that healthcare via transport and other means? Do they have the means to pay for this healthcare? What's their income like? Do they have health insurance? And what's their ability to engage with that healthcare? So are they able to actually, for example, adhere to the treatment they're given? So it's a really nice model that helps us think about healthcare access right across the healthcare journey. Earlier in this project, Barrington and colleagues conducted a scoping review where they looked at this model that Levesque had created and reflected on how well it fit the experiences of people with intellectual disability when accessing healthcare. They found that Levesque's model did reflect the experiences of people with intellectual disability, but needed a few modifications to truly reflect that experience. So the first modification they made to the model was to change the word ability to capacity. And this use of the word capacity reflects that people with intellectual disability can seek healthcare and access healthcare if they are given the right supports at the right time. They also added in the influence of social and historical context to the model. This recognizes that the historic influence of historic institutionalization and health segregation of people with intellectual disability has long-lasting effects on their access to healthcare, ranging from their failure to be included in health and disability policies, a lack of joint working between health and disability sectors, right through to a lack of services that are designed for the needs of people with intellectual disability. And thirdly, they added in the role of supporters, be that paid support workers or unpaid family and friends, as having a really important role in how people access healthcare. So they thought that they found that supporters can have a really important role in helping a person with intellectual disability to reach healthcare, to engage with that healthcare on reaching and then adhere to treatment. But they also felt that supporters had a really important role in guiding healthcare professionals in their interactions with people, because they could use their knowledge of the person and their rapport of with the person with intellectual disability to support that. I'll now pass on to Marianne, who'll talk through health literacy.
So in addition to looking at that model of access to healthcare, we've also been thinking about health literacy models and how they help us understand the way people access, understand, appraise, and apply health information. So this model here is by Sorensen and colleagues, and it is one of the most used models to understand health literacy. But something that's really important to keep in mind when we talk about health literacy is that it's not an individual accessing, understanding, appraising, and applying. Health literacy is a social action. All of us, understand health information with other people, whether it be our GP, whether it be information we find online, whether it be our friends and family. We are often trying to understand health, discuss health, make choices about health. I'm not alone, but through the information that we get from people and places around us. And that's really important to understand, because health literacy isn't up to an individual, it's a shared resource and it's a shared responsibility. So here we've tried to sort of visualize what that might mean. So it means that when we're thinking about how people access, understand, appraise, and use, for example, we're not just thinking about people with intellectual disability, we're thinking about how they interact with their healthcare professional and vice versa. We're thinking about the role support networks play in this interaction as well. And this interaction can be influenced by your environment. It can be influenced by things like your family environment and health literacy within the family, health behaviors in the family.
healthcare policies and systems, whether they facilitate access to information or impact it or impede it. Things like if you live in supported accommodation, what are the policies there? Do those policies facilitate accessing health information? Community and social support that's available, experiences of stigma and discrimination that can deny someone the right to information, and social media, which can make information a lot easier to access, but can also really kind of make you access information that's not very accurate or not very helpful for you. In addition to being influenced by the environment that you're in and the social environment, it's also influenced by personal factors like sexuality and gender. So we recently did a scoping review that found that LGBTQIA+ people with intellectual disability find it extremely hard to get sexual and reproductive health information. Language, can you find information that's in your language? Socioeconomic status can influence access, as can religion and culture can influence how available culturally appropriate information is for you. So we're thinking about that journey through the healthcare access system, and we're also thinking about the way that people are interacting with the information in that system, and whether that's easy or whether that's hard. And so based on those two models, we've started to think about particularly our qualitative fieldwork, where we went out and we spoke with different groups about their experiences. And so now we're going to take you through the key things that we've learned so far when talking to people about how we can make healthcare better. What we wanted to do as we take you through our key learnings is we wanted to use what's known as a social story. So a social story is a way that you can support people to understand new information or difficult information. You can support people to make choices with them. It basically follows someone through a journey, and you can stop at each point of the journey and you can think about that person's experiences. So we're going to go through the journey to accessing healthcare, and we're going to follow the experiences of someone that we will call George. So just to note, the social story that we've created today is based on all the qualitative fieldwork that we've done so far. We've thought about the things that people tell us are most common about their experiences when trying to get healthcare or give healthcare. And we've thought about the common barriers that keep coming up as we speak to people. We've tried to put those into this story to try and reflect back what some of those common experiences are. But it's important to note that people with intellectual disability are diverse, they're heterogeneous. So the experiences we talk about today aren't all the experiences that exist. And all the barriers and facilitators we talk about today aren't going to cover everything that people experience either. It's just focusing in on some of the key things that stood out to us when we spoke to people. So the first thing I'll do is I'll introduce you to George, who is a made-up person, just to clarify. So George is a 45-year-old man with intellectual disability who accesses supported independent living services in regional New South Wales. He's on the National Disability Insurance Scheme and has some community access core supports too. He has a known family history of heart disease, but he has not received a cardiovascular risk assessment in 5 years. So the first point of George's journey is trying to understand his health, so the capacity to perceive. And as I go through this part, maybe have a think about any barriers to healthcare that stick out to you at this point in George's journey. So George has never had the opportunity to access easy read resources about cardiovascular health, and that's his preferred way of communicating information. The heart health check is not promoted in a way that's very easy for him to understand. George's support workers are also not really aware of the heart health check. The SIL service and core support organisations don't really have specific policies regarding preventive health because they don't really see it as within their remit. And as such, George's support workers don't really talk to him about cardiovascular prevention either. So something that really came out to us when we spoke about people through their healthcare journeys is lots of people told us, not just people with intellectual disability, but also support networks, they told us that there was limited awareness or access to accessible health information. And the problem with that is if you can't even access information that supports you to learn about health or understand health, it becomes incredibly hard to know when maybe you need to go get a health check, when maybe something's going wrong. Likewise, if you're supporting someone with their health, but you also don't really have high health literacy, it becomes really, really hard to be able to support someone well. This was the biggest barrier that stood out to us when we spoke to people about this particular part of their healthcare journey. And there are lots of resources out there. But again, it just comes back to that awareness of knowing where they are. And if healthcare professionals know where they are they willing to use them? Do they have them ready for when appointments are needed? So we thought about this, and we also spoke to people about, well, what makes it actually easier to get information then? And people gave us ideas at both the service and professional level, as well as systemic and sector levels. And some of the main ideas that came out to us were ensuring that there are clear policies within services, whether it be a health service or a disability service, that supports workers to understand what their role is, what their responsibility is, how they can meet that responsibility. In addition to policy, though, you also need resources to make sure that they can ask questions if they're confused and they know how to support somebody with their health. We need to develop health literate organizations. This is both disability organizations and health services. And what that means is thinking about health information and access to health information from policy all the way through to practice, and making sure, again, that there are processes and guidelines for being able to achieve health literacy for different population groups that you might work with. Co-designing resources with people with intellectual disability and support networks, and also thinking about community outreach initiatives. So something that really stood out to us when we spoke to healthcare professionals is a number of healthcare professionals we spoke to had actually put together like community workshops, community education sessions that were targeted toward people with intellectual disability in the community to support them to understand things like, what does the health service offer? What's cancer screening? Sexual and reproductive health. So these community initiatives were really, really valuable for being able to support people who might not typically have access to health information to get that access. But also we need change at the systemic and sector level. We need clear roles and responsibilities for disability and health service workers when it comes to what their responsibility to preventive health is. We need training and education. And when we do public health promotion, we need to be thinking about people with intellectual disability as a target population who maybe have different communication needs. Monitoring the health literacy of the population is also important because it tells us where the gaps are and where we might need to put more effort or initiatives. As I mentioned before, there are lots of resources out there to support people to understand health that are accessible, but often people might not know where these resources are. So if you're thinking about trying to consider what a health literate organization is, for example, we have this resource here from Health Literacy Northern New South Wales. And this is basically a web page that provides checklists, strategies, actions for health services to undertake, which will help them design a service that facilitates access to information. Likewise, the Department of Health in Tasmania has put together checklists, actions, strategies, resources to help health services reflect on their practice and think about areas where they might want to improve or undertake a project in building health literacy. Something to note, though, is that most of the research on health literate organizations focuses on health services. So we don't know much about how we can support disability services to become health literate organizations too. So there is that gap currently in our understanding. One way that you might be able to fill that gap is through partnership and engagement, collaboration between health services and disability services to support each other to develop health literacy through their policy and through their practice. It can also bridge the gap that we often see between siloed services when joint projects such as this are undertaken. There's also a lot of resources out there to use at a more individual level or relational level. So here we have SECA, which is an organization that provides lots of information about sexual and reproductive health. They have web pages in Easy Read to support people to understand things like contraceptive options or STD screening. Women with Disabilities Australia launched their Neve website, which again, it's a website in Easy Read, and it really provides lots of health information to people in an accessible format. 3N, which is a part of the centre here, have also developed a number of resources in preventive health, particularly in cardiometabolic health. So that includes cards that people can just take with them to a doctor to say that they'd like to get a heart health check. So instead of having to remember what that is and what that might look like and what you need to ask for, you can just hand the card over. Cancer Council also has a number of easy read social stories to support people to know what to expect in cancer screening. We also have Gene Equal, who have put together a number of resources to help people understand genetic screening and genetic counseling and why they might want to pursue that and what that might look like in a way that's trauma informed. So there are a number of resources out there. One problem is the resources are scattered and it becomes really difficult to know where to go and what to look for. Something else that's really important to keep in mind, remembering that health literacy is social, it's not just about handing someone an easy read printout or giving them a link to an easy read website. It's about then supporting them to go through that information and understand it. So easy read is a first step, but it's by no means the only thing that needs to be done. Also, easy read is accessible for many people, but it's still not accessible for everyone. And so it's again trying to think about diverse ways that you can communicate information.
So let's go back to George's story. In this next stage of the healthcare journey, I'd like you to think about George's capacity to seek healthcare and the acceptability of that healthcare. So George has been to a GP before, but did not have a positive experience. George felt that his GP spoke to his support worker and that did not include George in decisions. His GP had a high number of people to see that day and had to keep their appointments short. George also feels uncomfortable in healthcare services. He feels that people stare at him and reception staff use confusing language and get frustrated with him if he does not understand. Because of this, George avoids healthcare services as much as possible and feels anxious if he has an appointment. So one of the first things that strikes us is that George has actually accessed healthcare before, but unfortunately these have been negative experiences. And some of the things that may have contributed to this negative experience is that George's GP only spoke to his support worker and didn't include George in decisions. This is an example of where the GP is failing to support George's decision making or help him make an informed consensual decision. The GP may have rushed the appointment because they had a limited amount of time for that appointment, and this reflects the kind of systemic barriers we see in health services where appointment times are limited. George also felt very uncomfortable in the healthcare service. He felt people were staring at him and the reception staff got frustrated at him. And these perceptions of stigma and discrimination will feed into this negative association George has with accessing healthcare. Some of the reasons the reception staff may have used this confusing language may be because of a lack of awareness or training on how to communicate with people with intellectual disability. And this emphasises the importance of having health literacy throughout your organisation, including reception staff. And because of this, George is avoiding reaching out to healthcare services. And this anxiety George now associates with healthcare creates further psychosocial barriers to seeking healthcare. So what can we do to improve George's experience of seeking healthcare? Well, at the service and professional level, we can engage in reflexive practice to improve communication and reasonable adjustments. As Marianne mentioned, we can organise community outreach to increase awareness of our services. And you can also organise walking tours with people with intellectual disability, where they can walk around your service and identify things in your service that are not accessible and could be improved. It's a really nice example of co-design that you can also do for things like communication tools. And it's really important that these communication tools are visible throughout your service, including at reception. And it's really helpful if you let your reception staff know if someone needs these reasonable adjustments ahead of time so they're able to engage in a more positive way. So just stopping and thinking about the reception area a bit, reception staff are often the first people that you meet in a healthcare service. So it's a really great opportunity to create this welcoming and inclusive environment. And reception staff are well placed to support people with intellectual disability with activities such as completing forms and paperwork, and also making further appointments, which can be quite complex processes. It's also great in your reception area to think about what service brochures you can have. These don't have to be written brochures. Audio and visual formats can work really well, particularly on complex topics like consumer rights and responsibilities. It's really important that people with intellectual disability can understand their right to consent and they're in making healthcare choices. So moving on to the next part of George's story, I'd like us to think about the availability of services and George's capacity to reach those services. So George's support workers recently received training from their employer in preventive health and healthcare. One of the support workers identified that George might benefit from a heart health checkup. The support worker encourages George to consider a checkup and talks to George about what this might involve using easy read resources to support George's understanding. George understands and says he does want to get a checkup. Unfortunately, there are logistical problems. The GP is 30 minutes away and does not do home checkups. The support worker's schedules do not line up with the available appointments, and their service is currently understaffed, and George's support hours are stretched. George cannot afford a taxi, and the last time he used public transport, he experienced verbal harassment, making him anxious about using it ever again, even with a support worker. So as we listen to this part of George's story, we notice that the GP is 30 minutes away and doesn't offer home checkups, and George can't afford to get there by taxi. So these illustrate the socioeconomic and geographic constraints that people with intellectual disability may face when trying to reach healthcare. We also notice that the support workers' schedules don't line up with the GP appointments, and this reflects the difficulties in the disability sector with support staff coordination. Furthermore, the service is understaffed, and we really unfortunately do see this turnover and staff shortages in the disability sector. George's personal support hours are already stretched, and this reflects the inflexibility we see in NDIS plans, where it's difficult to add on ad hoc support hours to meet appointment needs. The last time George used public transport, he also experienced verbal harassment. And this is an example of the kinds of experiences of discrimination in the community that people with intellectual disability can face, which pose further barriers in their capacity to reach healthcare. So what can we do to support George to get to appointments? Well, at the systemic and sector level, we can look to increase flexibility in NDIS funding so that people can get support to respond to ad hoc preventive health needs in a timely manner. We can also look to reform the siloed nature of disability and health sectors. So, for example, the NDIS does actually offer some funding for transport costs for health-related transport, but only under certain conditions, and this can be a source of confusion. We also need to increase resourcing in the disability sector to address staffing issues, and increase resourcing in the health sector to support home visits and flexible appointment times. As we move on to the next part of George's story, I'd like you to think about George's capacity to pay and the affordability of the service. So a support worker agrees to change their roster to support George to get to his GP appointment. However, this means that the support worker can no longer support George to get to his weekly trivia night, one of the few social groups that George attends. The GP is bulk billed. However, they note that George's weight is placing him at a greater risk of cardiovascular disease, and they want George to see a dietitian. The dietitians in George's local area have gap fees. George cannot afford these out-of-pocket fees. George finds a public allied health service, but is told that they don't see patients with NDIS funding or patients with a diagnosis of intellectual disability. This risks George's heart checkup losing its practical value, as he cannot follow up on recommendations. So the first thing we notice in this part of the story is that the support worker has actually managed to change their hours so that they can support George to the GP, which is fantastic, but it also comes at a cost because now George cannot socialise. So this shows the kind of sacrifices that have to be made when there is insufficient health funding in people's NDIS plan, and also when the process for updating that NDIS plan is so resource intensive, you're required to take from other areas of the plan. We also notice that the dietitian that the GP refers George to, in his local area, they have gap fees, which George cannot afford. And this reflects the socioeconomic disadvantage that many people with intellectual disability face, particularly those on disability pension payments. George does find a public allied health service, but at that service he's refused treatment on the grounds that they don't see patients with NDIS funding or with a diagnosis of intellectual disability. Now, this is a concerning misunderstanding we see among health service providers regarding the role of NDIS. Just because a patient has NDIS, they are still entitled to public health care. And refusal to treat someone on the grounds of them having an intellectual disability is actually discrimination on the basis of their disability. It's really concerning, and it means that George's heart health checkup actually loses its value as he cannot follow up on any recommendations. So what can we do to improve this? Well, we really need to see kind of system-wide reform, particularly that clarity among public healthcare services regarding their responsibility to people with intellectual disability and the role of NDIS. So just to reiterate what I said on the previous slide, just because someone has NDIS, they are still entitled to public healthcare services, and refusing to treat them on this grounds is discrimination. Within NDIS itself, we need to see greater flexibility to accommodate for these sudden changes in needs, which we often see in the healthcare environment. So as we move on to the next part of George's story, I'd like you to think about the appropriateness of the healthcare George has offered and his capacity to engage. So during the appointment with the GP, George receives advice about his cholesterol and blood pressure. However, George did not understand the advice he was given and did not receive a written copy of this advice. George does not know what to do next. The appointment risks losing its practical value, as George does not understand his cardiovascular risk or what his options are. The GP assumes George's support worker will remember the information and take it from there. However, the support worker feels as confused as George and does not know what questions to ask. They also feel the GP is placing too much responsibility on them for George's health. The GP did not know ahead of time that George might benefit from a longer appointment or accessible materials, and they need to get to the next person waiting to see them. They've also not seen many patients with intellectual disability and feel unsure about what to do or how to communicate. George again feels that he has had a negative experience with healthcare, reinforcing his feelings that it is pointless to seek healthcare. So in this part of George's story, the first thing we notice in that first paragraph is that George doesn't understand the advice he's given, and that advice isn't provided in written information. He doesn't understand the cardiovascular risk or what options he has to do next. This is a clear example of the dangers of inaccessible information and why it's so important that we get accessible information right for the person. One of the reasons the GP may not have been as clear as they could have been is because they assume that George's support worker will remember what they've said and take it from there. But we see in this example that the support worker doesn't understand what the GP has advised and also didn't know what questions to ask in the appointment, and they feel that there's been too much responsibility is put on them with the follow-up of the care. So this is an example of the assumptions that are often made that support workers have high levels of health literacy, which is not necessarily the case, and these assumptions can be quite dangerous. There's also a misunderstanding of the role of the support worker. While supporters can support the person to adhere to treatment, they themselves also need to be supported and guided by the healthcare professional. The GP didn't know ahead of time about that George might need a longer appointment or accessible materials. And again, these are just reasonable adjustments that could have made a big difference in how appropriate the appointment was. And also the GP was kind of unsure how to communicate with George. And this may be due to a lack of training. We know that healthcare professionals often don't receive much training or education on how to communicate with a person with intellectual disability. All of these things reinforce George's negative associations with seeking healthcare and reinforce this cycle of George no longer seeking preventive healthcare. So what can we do to improve this? Well, at the systemic and sector level, we'd like to see better training and education for healthcare professionals, particularly on reasonable adjustments. So that's things like communication aids, how to do familiarity appointments, and also how to kind of schedule bookings so that you can do them all at the same time, perhaps if you need to use anaesthetic, for example. Another recommendation that was actually made by the Royal Commission that Marianne mentioned earlier is developing navigator roles in healthcare systems. So Queensland is the first state to develop disability nurse navigator roles, and preliminary evaluation from this rollout is very positive, which indicates that this is a really great resource to help people navigate healthcare. At the service and professional level, there's plenty that can be done to improve communication. And things such as follow-up mechanisms can be really helpful. So for example, if you ask your patient to get a blood test, what are you doing to follow up on, help them remember to do that? Are you doing maybe automated reminders or checking in on them to see how they're getting on with doing that follow-up step? And this can help with treatment adherence. I'll pass back to Marianne to talk a bit more about adjusting communication.
So when we were speaking to people, people with intellectual disability, support networks, healthcare professionals, communication was one of the biggest barriers that kept coming up, whether it be communication between people with intellectual disability and the healthcare professional or support networks and the healthcare professional. And some of the healthcare professionals we spoke to told us about the different ways that they've tried to break down those barriers. So one told us about how they use models of the body, so breast models, for example, to support people to understand what breast cancer is and what breast screening is. You can see that there in that first quote. And really driving home the issue of communication is that second quote there, where the healthcare professional said it really comes back as a primary issue, even above things like having good awareness of intellectual disability health. Because if people have the ability to modulate how they communicate and adapt how they communicate, then the healthcare that they're providing someone becomes so much more impactful. It becomes something that that person can actually act on. So there's lots of strategies out there to support with finding different ways to communicate. A really common one is teach back. And teach back is when you explain a concept to someone in plain English and you ask them to explain it back to you in their own words. You can check for any gaps in understanding and then you can clarify those through the same process. Teach back, there is a CPD certified course by Cesslet and Deacon, which you can do online here at teachback.org. And this is a communication strategy that doesn't just support people with intellectual disability. It's shown really good outcomes in lots of different groups and communities, including culturally and linguistically diverse communities. There's also things like healthcare documents that people might want to share with their healthcare professional to support their healthcare professional to work with them. For example, CID launched their My Health Matters folder, and this folder gives information about the person, including their medical information, but it also gives a healthcare professional tools and knowledge to really support how they work with that person. So here's just a screenshot from inside that folder. You can see here it lets people write down the ways that they communicate yes and the ways that they communicate no, because that can look really different for lots of people. This folder can be printed on the website, but it can also, a hard copy can also be ordered from CID too. Similarly, hospital passports can often be used by people to support that communication. This is an example from Women with Disabilities Australia. And again, it just summarizes all the key information needed, not just about someone's medical health, but also about how they communicate, what their preferences are, what reasonable adjustments they might need. Healthcare professionals that we spoke to really valued these sorts of tools in how they worked with people. So this healthcare professional said, when they come with that, referring to a hospital passport, there's so much more information in there, and it's so much easier to treat somebody if you have that information. However, healthcare professionals also told us that something that can typically happen is sometimes those documents get dismissed. And so it's really important to understand the value of the information someone's willing to share with you about themselves. Likewise, health plans can also be a really helpful tool, particularly to coordinate that care between people with intellectual disability support networks and healthcare professionals. And it can really help with the role confusion that can sometimes occur. So Aruma, for example, have put together medication plans and mental health plans to support those three groups to work together well. And again, a support worker that we spoke to really highlighted what they saw as role confusion being a massive barrier to how effective preventive healthcare can be. What that refers to when I say role confusion is support networks not fully understanding what the GP is expecting from them, the GP not really understanding what the support network's expecting from them, the person with intellectual disability not being included in the conversation. So it's really valuable to have these sorts of physical resources that can facilitate that coordination. So I'm going to go through some of the take-home messages that we'd really like to, I guess, emphasize from this presentation. One is that we need health literate disability organizations. So health literacy through policy right down to practice, strategies, resources for achieving this. We also need disability literate health organizations, so understanding among healthcare professionals about disability health and communication adjustments that they can make, reasonable adjustments that they can make, what the NDIS is. To achieve both of those would require systemic reform that really breaks down the silo between the two sectors and encourages better collaboration. We also need accessible information to support health literacy, not just of people with intellectual disability, but also their support networks. Coordination and communication of care, and better implementation and identification of reasonable adjustments that can be made. I'm going to hand over to my colleague Sue now, who reflected on some of the things we learned in our interviews and put together what she thinks are the really core things needed for healthcare professionals to improve access to preventive healthcare.
Doctors can use easy read, speak clearly, being kind and helpful.
Sue has also put together what she thinks are the key things for the sectors, the health and disability sectors, to do.
Give good doctors training. Let doctors have more time.
Thank you so much, Sue. So that brings us to the end of our webinar. And so very happy to take any questions that anybody might have.
Thank you, Marianne, Siobhan, and Susan for your great presentation. We will now have time for questions. Please put your questions in the Q&A box. Okay, Marianne, Siobhan, and Susan. The first question is, has AI changed the framework to creating individualized roadmaps for healthcare supports?
Yeah, so I think we've discussed AI a bit as a team in terms of the role that it might be able to play in accessible information and individualizing care plans. I think there's definitely potential there to really streamline some of the work that gets put into trying to coordinate the care. And so, I certainly think it could have a role in supporting people and trying to reduce some of the workload that people can often see as a barrier to being able to provide the care that they want to provide. And it can also really facilitate accessible health information too. So as a team, we've been using AI a little bit to see how it can help us in our work together.
The next question, are there specific strategies to reach people with an intellectual disability who are less likely to engage with health services? Precisely, such as people in group homes or those who have little family support, who are even less likely to engage in preventative care.
Yeah, that's an excellent question. So you want to go? Do you want me to go? You can. Okay. Do you have any ideas for that, Sue? How to reach people that are difficult to reach?
Mean home care.
Yeah.
Home care is good, but not all home cares can do things like they can do.
Yes, yeah, can be difficult. I think some of the strategies that we've seen come through, so like we spoke about before, there were quite a few nurses that we spoke to who had put so much effort into community initiatives, and nurses who introduced themselves to local disability services so that they could maybe come for like a half a day and do a kind of workshop, or so that that service knew about the services that that healthcare provider can provide, and who's eligible for it and how the people in their care can access that. So I think really to reach hard to reach people, it's just breaking down those barriers between different organizations and letting them see how they can actually support each other in those really difficult parts of their work.
Do you think confusion, misunderstanding about the role of support worker exists for healthcare professionals? For example, that support worker may be there to consent, make decisions, interpret, and explain. Remember info. Does there need to be education for a HCP to understand what support worker does not do?
I think definitely from what we've seen in the qualitative fieldwork, we spoke to a number of support workers who felt very much that they were being perceived as some kind of extra healthcare professional, and that there was just lots and lots of responsibility placed on them that sort of exceeded the actual role that they were fulfilling. So I think, like we mentioned, disability literacy in the health sector, that includes understanding what is a support worker, what can they support with, what really isn't their role and isn't really appropriate to be asking them to do.
The next question: has your qualitative data been published?
So we're in the process of writing up now. So we're hoping within the next 12 months, we'll be able to get some of that work out and published.
That's all we have time for now. Thank you, everyone, for joining us for today's webinar. Please make sure you visit the Centre's website and subscribe to the newsletter. Please also stay on the Zoom once we close the webinar to do a short survey. Thank you for joining us.